presentations, don't go with the idea as a very difficult procedure. Looking into all the ways of marking and investigations, don't get disheartened. It's a simple surgery, and planning is also very simple. Yes, there's a lot of new things that come up which makes things sometimes difficult, but it makes things very, very precise to get a good outcome in your patients. Pre-op assessment we talked about very nicely, discussed the various points to get various things. Various platforms are there to calculate your toric calculations, which can be Alcon platform if you are using Alcon lenses. If you are using Oro, you have their calculator. Hoya, they have a calculators. But things should be simple for you. Whichever thing you are using should be simple and more reproducible as you have. So recently we have been using both Alcon and Hoya eye trace systems to check which is better. And comparing almost 500 cases, we realized that both are equally good. But Hoya has the advantage of giving you accessible other range of toricity which you aim for a post-refractive, post-cataract surgery refraction wise. If you see here, you can always go for either, as we discussed, little towards the against the rule or little towards the with the rule astigmatism can be planned in this calculator. So in way, this is a better way to calculate. But looking to surgery wise, nothing different than a routine surgery which you do. There are 5 steps to really enhance your surgical skill on getting good toric implantation in your patient. As we discussed the pre-op factors, that's mean getting a keratometric cylinder or a topographic cylinder for your patients, not refractive cylinder. And then marking a good reference and axis marking your patient, then doing a good phacosurgery and actually then getting an IOL to be aligned to an axis you have marked. So that is very, very important steps. This we have discussed. Again, this is the initial phase of all things. We always use a perpendicular marker or anything which gives you absolutely good visibility of 6 o'clock area. Nothing better than anything which is perpendicular to the cornea. Especially, I do it sometimes without a pupillary dilatation, so you get a good centration there also. But most patients for cataract surgery will have a pupillary dilatation, but that can also be done there. Subsequently, you can use 3 markers also. If you have 2 markings, then you have a better orientation of 3 to 9 o'clock position by whichever method you are using. It can be appellation tonometry method, or you can use a bubble marker. In these cases, will give you a very good marking. In this patient, I am using a bubble marker which gives you exactly 3-point marking in your patients. Subsequently, on the patient eye, you can reorient the axis. So this is what beginning of for initial practice for a toric IOL. If I just summarize my 5 years experience, started with just a 0% of toric lenses. Today I am using around 17 to 19% of my practice is toric IOLs. Then other thing, variant was talked about Alcon method, which is supposed to be good for orientation, but recently I have been working with the Callisto eye system with Jais, with their microscope and IOL master, which will take the picture from the patient's eye, from the IOL master. It takes into consideration of both the half of the corneal limbus. Then this picture, vessels are oriented here, and this is the microscopic picture. This is a picture from the IOL master. Each vessel orientation is matched. Once you have a vessel orientation match, that gives a good alignment of the patient and gives a good central limbus orientation. It also gives you an incision orientation for a main incision as well as your side port incision also oriented to this, and gives a very good marking for rhexis. The rhexis size and shape can be decided by your own techniques, but important thing is this rhexis orientation also takes into consideration angle alpha of the patient. So these are 2 important things associated with this alignment system with Callisto, which is also true for a Variant also. But looking to surgical implantation of these lenses with the help of a Callisto system, once you have a complete surgery, the bag is filled with viscoelastic, nice circular rhexis should be there to have a very good predictable outcome in a post-op period. I think the IOL should be such which has a better track record in terms of their stability, and the designs with the Alcon toric lenses has been really good in the literature also. The rotation of not more than 4 to 7 degrees. The removal of viscoelastic from anterior part and the posterior part of the bag is very, very important to decrease the post-op rotation in these patients. Once you complete the things, just keep it around 1 to 2 degrees from the main axis you require. This is the orientation which is given through the initial toric calculation and image alignment process by Callisto. It gives a very nice orientation. It has 3 lines. The central line is the one which is the actual axis, which is just a 0 degree, and two lines are just 2 degree apart. So if you get the central line attached, that's the best way you can do it. So there are other ways to get a better refractive outcome, which I think going to come in India also. Intra-op wavefront abrometry and refraction will give you a future. But eye trace was initial one which I use in between also. As it's been showed, you have initial marking, manual marking, then do eye trace, and that gives you a new orientation of axis implantation. And in fact, if I tell you the surgery is not different, and we compare the eye trace marking system with the 3 points with bubble marker, the ultimate post-op results are not very different. So you don't really require a very high-tech instrument. Sometimes it is the repeatability of procedure which you do makes your surgery much more comfortable, and implantation on an axis you have marked is very, very important. The surgery is very simple in these cases. As you normally do it, complete a phaco, align your lens. After you implant the lens, little bit of polishing of anterior capsule, posterior capsule, and removal of viscoelastic. And this is to show that this mark which I have here is a little thicker, which is almost a 3 degree mark. So this may be another factor for a little bit of a shift from the axis which you desire in your patient. The mark which you do manually should be very sharp and thin. In that way, I appreciate that stromal puncture may be a better idea to have a very small linear mark in your patients. Just to see another way of implanting a patient of toric IOL, if you see the lens has been implanted, we remove the viscoelastic, just leave the lens. I normally would do it after hydration. This is leave around 2 to 3 degree or 5 degree against anti-clockwise. Then hydrate your wound, make the chamber stable, use VSS solution with Helon cannula or a 27 gauge cannula, maintain the pressure. Just align these 3 marks to the thin linear mark we have achieved. I think if that consideration is taken care of, don't over-rotate the thing, otherwise you'll have to rotate the entire lens, entire 360 degree, because you can't go anti-clockwise rotation in your lenses. This is literature showing that various 4 markings which have been done, and they had almost similar results. Post-op is, I think, very important area. You must see your patient in the post-op period. If your vision and refraction not matching in patient's comfort, then dilate and see how much rotation you have, and nothing better than eye trace, which can give you a real post-op orientation of your lenses. And this will also tell you if patient vision is not better, patient is uncomfortable, you may have to plan re-rotation. And this abrometry picture also tells you if your lens axis and corneal astigmatism axis is not matching, the patient will not be very comfortable. So this is one of my post-op patient with 15 degree away from the main axis which I desired. So in that situation, if patient vision is not better than 6-9 parts or 6-6, then this is the patient you require to re-rotate. But there are some patients, despite having a 15 to 16 degree rotation picked up by eye trace, may not have a poor vision. In those cases, you don't have to do anything. So it's not only the picture you get it, the patient's total picture has to be taken into consideration. These are a few of my results in last year's one. And you can see T3, T4 is the commonest lenses used for implantation in these patients, because most patients will be within 2 diopter cylinder. But there are patients who have a high cylinder also, and against the rule astigmatism will be the largest group of patients than with the rule astigmatism, because most older patients, as we discussed, will have against the rule astigmatism. Therefore, your initial planning has to be little better. Think of a shift which can have with the age change. And if you keep the patient little with the rule astigmatism, they have a better depth perception and hysteresis. So that should be consideration for all our patients. The results are very good and fantastic with newer ways to looking into axis orientation. But I would say surgery is much more important than looking for other things. The planning is important. Surgery is equally important for your categories. Therefore, initial your 100-200 patient or routine fake